All right, well, good morning, everybody.
Good morning.
So good morning and welcome to our guests. Are joining us this morning, we have Dr. Lenga, who Keith will introduce us to more formally in a moment. And joining us from the Uxbridge Club is Connie Duro and the president, Michael Vaughn. So welcome. They're sort of seeing how our hybrids work so that they can hopefully in turn do the same. So welcome, everybody. Our land acknowledgement is we'd like to acknowledge that here in Bowmanville, we're on the territory covered by the Williams Treaty, and that this land is the traditional territory of the Mississaugas of Scugog Island First Nation. We offer our gratitude to Indigenous peoples for their care of the land and their teachings about our earth. Invocation. Anybody? No Don Gleed yet? Well, I have a spare one, but I've said it 3 times now. So
Give her all good.
So
before
there we go. We'll do the Rotary Grace.
And Rotary ways help us to serve all our days.
Very good. The Rotary Grace. It's we used to sing it. You don't want me to sing it. Birthdays and anniversaries. Do we have any birthdays or anniversaries, Polly?
President Amy, there are no birthdays, there are no anniversaries, but where's Renee Boss? This lady celebrates 16 years of service about stuff.
Thank you, Renee.
And Kevin Miller, I'm not sure it was on the call, but Kevin has been with us 3 years. So thank you, Kevin.
Very good. Thank you. So moving right along, we're for our Uxbridge friends, we kind of, do it one way and then the other. And so we started having our speakers first, just because it's a busy day. So Keith, I believe you're still on there with us. I can see you there. Keith is going to introduce our speaker this morning.
Hello, everybody. Okay, I'm pleased to introduce Dr. Ilan Lenga, Chief Information Officer, Chief Medical Information Officer. Dr. Ilan Lenga joined Lakeridge Health in 2004 and has dedicated his career to advancing the organization in medical information management and technology, promoting standardized care and improving data quality. As the CMIO, he is responsible for digital transformation at the organization and has played a key leadership role in the procurement of the clinical information system for the hospitals across Ontario's Central East region, and continues to lead implementation and governance of this system for both Lakeridge Health and the Central East region. In addition, Dr. Lenga serves as a digital health lead for the Durham, Ontario Health Team, which is advancing virtual care, data sharing, and analytics throughout Durham region. He's a computer programmer and has written and developed healthcare-related computer and mobile phone applications. Dr. Lenga is also a practicing nephrologist at Lakeridge Health, a lecturer at the University of Ontario, and an adjunct assistant professor at Queen's University. Please help me welcome Dr. Ilan Lenga.
All right, thanks everybody. Quick mic check. Can you guys hear me?
Yeah, you're good.
Excellent. So thank you, Keith. And I'm really excited to be able to present to the Bowmanville Rotary Club. We stand now at just a little bit over 2 weeks from what we like to call our epic transformation. This is the largest clinical transformation project undertaken, not just at Lakeridge Health, but across the entire Central East region, and is the culmination of a multi-year effort to modernize our IT systems. So this is happening in just a couple of weeks. We've been hard at work at this for years, actually, and really exciting to be at this point. And I think you'll understand in just a few minutes why we call it an epic transformation. The first reason we call it epic is because it is epic in size. This is an initiative to create a single health information system across all the acute care settings throughout the Central East region. So that is 13 different hospitals. So the 5 hospitals of Lakeridge Health, 3 hospitals of the Scarborough Health Network, and then Campbellford, Halliburton Highlands, Northumberland, Peterborough, and Ross Memorial. All of us will be on a single medical record, and that spans roughly 1.5 million Ontarians and is the largest instance of a healthcare record in Ontario. So pretty epic stuff. The second reason we call it epic is because it is epic in its intent. And it's got really three main goals that we're trying to achieve. The first is to bring modern systems to be able to provide an enhanced clinical quality and safety, so that we can make sure all the care that we provide you and your loved ones is evidence-based and is standardized and is following best practices. The second is that we want to empower you and patients in our region to participate in their care through improved access to their information and improved access to the care team. And then third is that we actually want our care teams themselves to be able to benefit from the use of the most modern and sophisticated tools to do their job, and really to have a comprehensive view of the patient in real time. Right now, if a patient goes to Campbellford and then shows up in Bowmanville, their medical record is completely fragmented and it's very difficult to put the story together. We intend to fix that with this EPIC project. The third reason that it's called EPIC is because the actual software we're putting in place is called EPIC. And EPIC is one of the world's largest providers of electronic health record. In fact, in the United States, about 2/3 of all health records are in an EPIC system. So this is a massive company that has been very successful in making these kinds of changes in health records across the world, and particularly in the United States. It really is a comprehensive medical record. It has the most modern tools, such as what is called computerized prescriber order entry, which means doctors and nurse practitioners are putting the orders in directly themselves. So there's no risk of transcription errors. And they're documenting everything online so it can be shared through by all the practitioners that are part of a care team. It's got the usual administration functions. It's got some pretty cool communication tools between providers. And what we call state-of-the-art workflows, like barcode medication administration. So patients wear a barcode armband when they're in the hospital. We scan that, we scan the medication. So we always make sure that the right medication is going to the right person. Do the same thing for labs. The system has got all sorts of algorithms and AI tools to help with what we call clinical decision support, to help our practitioners do the best, make the best decisions and do the right thing in every situation. And then once it's got the data inside it, you can do some pretty sophisticated analytics to start looking at opportunities for quality improvement and population health. We're joining a pretty rarefied group of hospitals that have started to use EPIC in the United States and in Canada. Some of the US ones you will no doubt recognize. You've probably heard of Johns Hopkins, Cleveland Clinic, Stanford, Mass General, Mayo Clinic. All of them run EPIC as their health information system. And as you can see in the top block, many Canadian organizations have already embraced this software. And in fact, Alberta, the entire province, is on a single instance of EPIC. And so our 7 hospitals are at the top: Hamilton, Trillium, Ottawa, and coming online in June will be Hamilton Health Sciences and UHN. And once they're participating in the use of EPIC, the sharing of information and skills becomes that much more possible between these hospitals.
Sorry, Ilan, are you sharing something?
I am. Is that not showing up on the screen?
No, we're only seeing you. Sorry.
Oh, I'm so sorry. Is that better?
That's it. Yep.
Oh, I had the nice blue box around my screen and I thought everything was going well. I wish you had told me earlier. I'm going to just flip back for a couple of slides just so people know what the heck I was talking about. Okay.
Thanks.
That's the region that's going live with EPIC. Boy, Keith, you should have told me this earlier. Those are the 3 reasons that we're doing EPIC. My goodness. Here is an aerial photo of the EPIC campus in Wisconsin. I didn't miss too much. And here are all the logos of all the hospitals that I mentioned. And I think we're caught up. Okay, so you didn't miss too much. This is an important slide, so I'm glad you caught me at this point. And that is that it's really hard to overstate how big a transition this is going to be. We are using a health record system that is 40 years old and very fragmented. Most patients in the hospital have 3 charts that have their information separated between them. And the electronic system that we use today was developed 40 years ago. It's on the little screen there if you can see it, but it's entirely DOS-based and text-based. And that's what we've been using and continue to use, actually, at least for the next 2 weeks. We are moving into what you see on the right-hand side, which is a true modern medication and health record system. And as you can see, fancy graphs, lots of color and labeled things, and even avatars of patients to help us manage their care. There's a little close-up for you of just how different it will look. And this will be an entirely paperless system. We will stop using trees at our hospital for medical records and move on to electrons. So here is what a modern workflow looks like for a nurse. So this is what they call the brain. It helps organize the nurse throughout the day to make sure that every hour of the day, they know the tasks that they actually have to do. That's a pretty big difference from what they do today, where everything is on paper, sometimes writing it down on a piece of paper for themselves and later trying to transcribe it. And they have to sort of collate the things they have to do in the day, which, as you can imagine, runs the risk of forgetting something or not documenting something properly. The other big enhancement we're going to have is something called closed loop medication systems. As I mentioned, physicians will be entering their orders directly into the system. That then allows the order to be communicated directly with the inpatient pharmacies. Pharmacists can verify it. We have automated dispensing machines, which will then dispense the actual medication. It's then delivered to the patient at the patient location in the hospital. And then lastly, as I mentioned, we're going to be using barcode scanners to ensure that we have the right medication and the right patient and reduce medical error that way. Once that administration is done, the doctor is aware that that administration is done and then can modify their treatment based on the response. And that's what's called a closed loop medication system, and what we'll have in place in just a couple of weeks. The idea of doing this is actually very evidence-based in terms of reducing patient harm and improving processes in the hospital. So there's a bunch of studies on this, somewhere in the range of 45 to 77% reduction in observed adverse drug events, and a 10% reduction in those kinds of events that actually cause harm, which is a very, very significant drop in one of the most common causes of injury to patients' health when they're in the hospital, is a medication adverse event. The actual time it takes to administer the medication is reduced by about an hour, which is pretty significant. And that comes from the fact that the number of steps in medication administration, right now, there's about 17 steps required from the decision to order something to it actually getting into a patient, and using a closed loop system reduces that down to 5 steps. And so really big process improvements and really big patient safety improvement. The other thing I mentioned was about enabling patients to be part of their care team and be much more aware of their health status. And to do that, we are rolling out the system called MyChart, which is part of the Epic platform. Now, some of you may already be using the current portal that we have in our current hospital, which happens to also be called MyChart. So we are going from MyChart to MyChart, but although the name is the same, its features are much more extensive. And the other thing is that this MyChart that you'll have access to if you are at the hospital and register will span the entire Central East region. So it won't matter what hospital you go to out of the 13 hospitals that I mentioned, you will have the same experience and the same access to your records. So a single portal across the region, a streamlined activation and enrollment process for those who want to have MyChart, and we're going to be encouraging it. You'll have the ability to view any scheduled appointments you have at any of those hospitals, review the results and the clinical notes that have been generated for your visits or your inpatient stays. You can share that access with other providers, family, friends, caregivers. It's your decision as to who you share your MyChart access with. And there are also patient education materials that can be delivered through MyChart. So stay tuned. There's going to be sort of an advertising blitz about this, but also every time you interact with the hospital, we will be promoting this and hoping that folks use it as an important way to stay connected to your care. Here's just a little screenshot of what it looks like. So you can look at your visits, you can receive messages from the hospital, review your test results and medications. Here's sort of like a timeline of what's happening with you. and your ability to get messages from your care team.
Jackson.
So I mentioned that we're about 2 weeks out. Our big launch date is December 3rd. And we've got the whole team working really hard to get to this, which is why I don't know how Keith is making this meeting, but both he and I have to get back to this because we are going live in just 16 days. How will we be keeping the public informed about this? Well, this was a good opportunity, and I appreciate the opportunity to come and talk to your club. But we are going to be heavily promoting this big change up through our website. We're beginning a social media campaign around this, videos, there'll be signage around the hospital. An important part of this is that patients need to understand that we will be very much under construction for the first couple of weeks after go live. It's not construction that you're going to be able to see if you come into the hospital, but it's as significant as if we were building an entire new wing to the hospital and populating it. So lots of little things will be needing to be ironed out as we go live. And so we'll be asking for the public to bear with us. Hospital TVs will be explaining all of that. We'll be handing out patient information, pamphlets and advice for those patients in the hospital when we do that transition. And of course, we've been sending out information to community partners as well as MPPs and municipal leaders so that they're aware of our big change. So sorry about the no slides at the beginning. I hope I caught you up and that you have a good sense of what's coming in just a couple of weeks, but certainly happy to answer questions about this undertaking of ours. And thank you again for having me.
Thank you, Dr. Lenga. Are there questions? Yeah. Joe?
Yeah, hi, Dr.
Lenga.
Lenga. Thanks very much for this. This is great. I know you've been working hard. This is, I guess this is the e-health whole e-health thing that they were talking about. Anyway, what you're talking a lot about hospitals, but you know, for a lot of us, we don't really see the hospital. We see our family doctors, our family physicians, our motor specialists. And in my case as well, you know, my mother just went into a long-term care home here in Bowmanville. Where do they fit in, the non-hospital practitioners, health practitioners?
Yeah, so it's a really good question. It's a question I actually get often, which is, okay, great, you've done the 13 acute care hospitals in our region. Like, what's next? How are we going to truly have an integrated healthcare system? The answer is that we have to get over a lot of barriers to make that happen. There is no hospital information system, no matter which one we picked, that integrates with primary care medical information systems. It just doesn't happen. It's like Windows and Apple. So we have to get past the vendors being proprietary about their information. The good news is that this is a very big movement, not just in Canada, but throughout the United States, to increase interoperability between information systems and information transfer. So on the one hand, we're putting pressure on vendors to be in a position where data can be shared, but we're also leading this on an Ontario level to look at what we call digital health information exchanges, where everybody is in a position to be able to provide data into a pool, we'll call it. That pool can then be shared out across providers. So this is a big step towards being able to do that, but there's still many steps ahead before we'll actually be able to have seamless information transfer between all the systems. In the meantime, what we do is we will be providing not just the MyChart portal to patients, but something called Epicare Link, which is a provider portal to any practitioner, any community partner, so that they can see the hospital record. It won't seamlessly go into their electronic health record in their office, but they'll be able to see everything that's been happening with you in the hospital in the same way that the people in the hospital can. So if they're part of your circle of care, if you've said, yep, that's my primary care practitioner, we'll allow them to see your chart. And so that we improve information exchange that way. There's also lots of little projects to pull certain pieces of information together, and we're building and building on that to get to that sort of utopian future where you only have to tell your story once. And as long as you've given us permission, we can share your story with other practitioners so that we all know what's going on with you and not depending on you to be the courier of all information between healthcare providers. So big step forward, but many steps yet to come.
Great.
Yeah. John?
I think it's a tremendous advancement making. As an engineer, I'm always looking for backup. My question is, in the event of a crash, what do you have in place?
So excellent question, and something you can imagine we're pretty sensitive to as well. We've taken our big leap forward with this and said that we are going to make our information system mission critical, that it is the most important tool we will have in the hospital and where all the information will reside. Now, you can imagine we have a downtime procedure in the event of a complete loss of the system. And that is boxes on the ward that say, you know, open in case of emergency, which have those tree products in them, and pens and all the things we still remember how to use in the event of real trouble. So we will never let a patient safety issue be caused by a downtime, but it's certainly very frustrating and a lot of catch up to do when we get back online. What we have done to prevent that from occurring in the first place is really invested in the infrastructure that runs this thing. And so we have a big data center in Markham that is in Barrie, which is our main system, is our primary data center. And we have a secondary data center, which runs in something you're probably familiar with, which is Amazon Web Services. So in the event that the entire primary data center goes down, we can shift the entire infrastructure with a complete copy of all information to Amazon Web Services. We have redundant internet links to both systems. And in the event that somehow both of those go down, we can still reach the data center over the internet. And we have a pretty significant connection over the internet to be able to reach that system as well. So essentially 3 paths to get to each data center. And so we'd have to have a complete shutdown, loss of both data centers, one of which runs on Amazon, which is very redundant on its own, and a loss of multiple forms of connectivity for that to happen. So the likelihood of that, we believe, is now very low, although not impossible. In the event that somehow that still happens, we've got paper. And so we can still use all of our systems and provide care and catch up on all the data and ordering afterwards.
Boy, technology. Chris?
Is this a local health authority initiative, or is that a whole province, Ontario province initiative? And if not Ontario-wide, why is that the case?
Yeah, so it's not Ontario-wide. It's in fact the 7 organizations and 13 hospitals chose to do this together. Now that's under the direction of what's called the Health Information Renewal, initiative by the Ministry of Health, which asked hospitals to form clusters like this in investing in new information systems. But this was our region choosing to work together and procuring this system together. And one of the things that is, I think, misunderstood in healthcare is that hospitals are actually private entities that are publicly funded. So we always think of everything as being run by the province. Well, the money certainly comes from the province, but each hospital does have its own autonomy and has its own board of directors to make the decisions as to how that money is used. And so this is a pretty big accomplishment to have 7 organizations and their boards agree to procure something of this significance together.
Are there any questions from our online folks? I can't see everybody, but if there is, just speak up. Yeah.
Sure, I've got one. Listen, John woke up the geek in me. So I'm a disaster recovery guy, so I appreciate what you said about the data centers. Have you created an air brake to protect yourself against ransomware, which is maybe a bigger threat than a physical outage or an application failure?
Yeah, so a true air brake is not possible in this kind of scenario, but we have definitely made cybersecurity a priority. The larger the instance, the bigger the target. And so the idea of being, protected by obscurity is not really going to work now that we're going to be the biggest instance in Ontario. So we are investing in cybersecurity for sure. We have also just been approved by Ontario Health to be what is called a regional security operations center. And so that means we have extra funding to invest in cybersecurity to protect not just the actual asset, the Epic system, but in fact, all of our systems at the hospital, which are other, of course, vectors for these nasty things to get in. And we will also be extending that to other hospitals. So as the regional operations center, Michael Guerin Hospital, Northrop General Hospital have asked if we can provide services to them as well. So that, I mean, everyone will benefit from that, but the fact that that will be housed in our region will ensure that our systems kind of are front of the line in all of these investments around security. So it's impossible to be 100% protected, as you well know. Lots of backups exist in the system, including local backups. So in the event that we lose the infrastructure due to ransomware, there are local copies on good old-fashioned PCs that are backing up things. So that's sort of one of our last ways of protection in the event of a cyber attack. And as I say, paper, if all else fails. But ultimately, it's about investing in cybersecurity and staying at least up to pace with, and maybe even slightly ahead of the bad guys if we can, and making sure that we are prioritizing that, which we are.
Very good.
Thank you.
Yeah, what kind of communication is your Epic or our Epic going to have with the Epics in, I don't know, Toronto or Sudbury or something? If I, get in a car accident and I'm in the hospital in Sudbury, are they going to be able to talk to each other?
They sure do. And that's one of the big steps forward in interoperability. Again, we're sort of living within that vendor space, but Epic systems talk to other Epic systems very well. And the term they use for it is called Care Everywhere. All of the instances in Ontario have agreed to turn on this feature of Care Everywhere, which means that we can see your records in one of those Epic hospitals. It looks like it's right inside the main chart that we're seeing. It's a little symbol that tells us that it's coming from an outside source. Some sources demand that we go through a release of information process with you. Some have the philosophy that if you're in the Ontario mix, it would be an automatic approval. You still have to ask for it, but it would be approved if it's by another healthcare professional. So different hospitals have a different system, but it's all has the potential to be seamless. Or I can click and say, I want to see that record from UHN. If UHN permits it, then I get the record right away into the system, and it's in line with all of your other notes. So Epic to Epic is really easy. We are now working on an initiative to see how far we can go with other acute care systems. So there are systems, the other main ones are Cerner and Meditech. And there is an initiative that will go on for the next couple of years to improve interoperability between other acute care hospital systems as well. And then, as I mentioned before, the grand dream of office systems as well. But yeah, Epic to Epic is all set up and easy to use.
Fantastic. Well, thank you very much. Sorry,
Leanna.
Leanna?
Hi.
Yeah.
Hi, I'm just wondering with, sounds like a big change. How are nurses and doctors finding it for input? A lot of older doctors, maybe, is anybody having a challenge with the fact that it's all computerized now? And what's the deal with the actual people doing the input?
So ask me again in 16 days.
Yeah.
But over the last couple of months, we have been going through and continue to go through a very extensive training program. And so doctors do about 6 hours of training, nurses somewhere between 8 and 16 hours of training to use the system. We're following it up with all sorts of training manuals that go along with it, quick access cards of what to remind you of what you need to do with the system. And for the first 4 weeks after we go live, we will have what I like to call an army of support. So these are what we call super users and at the elbow supports. They're going to be wearing like yellow vests. There are Genius Bar of the hospital. They're going to be deployed everywhere throughout these hospitals to help people in using the system. We're also going to have like a remote access system where they can click on a button, start a chat. They can take over their screen, help them through the workflow, and make sure that they have done things correctly in the system. You're right. There are those who have embraced it. I've heard people say to me, this is great and easy. I've had other people who feel like deer in the headlights. And we sort of have a support strategy for all of them. And as you know, the mind share and the experience goes up in the organization, we're expecting peer-to-peer support as well, as those comfortable will help those less comfortable. But we've got a really strong support strategy in place to help with this transition. But we know it's going to be a big transition for folks.
I have a quick question.
Yeah.
So once the doctors and nurses are all up and they're doing it, what happens to the support staff in the hospital, the ward clerks who would have been inputting most of this information? Do they lose their jobs?
So I would say that jobs are changing for sure. There are certain tasks that we will no longer require. But in general, we're doing more to improve healthcare across our system by doing this. So and this is probably true of every IT transformation I've ever seen. We always think about the jobs it's cutting. We forget about the fact that we're going to be doing something far bigger and far grander than we did before. And so the activity level goes up in so many other areas of the hospital. And so we are talking to many of these folks, like transcriptionists, like unit clerks, who were doing these tasks before that will be replaced by the system, and looking to retrain them in other tasks that get newly created by the fact that we've put in new IT systems throughout the hospital. All those need to be supported. So we have a big job transition effort with our HR folks to ensure that folks have a transition rather than a departure.
All right, big changes, but for somebody who grew up in a hospital, my father was a kidney patient, so the nephrologist would understand that. Boy, a lot of changes in the 30 years since he's been gone. But what a great thing. If you can, like you said, Joe, if you get an accident in Toronto, they can just have your medical records like that. So excellent. So thank you very much, Dr. Lenga, for joining us. I know you're probably busy and have to jump off 16 days and counting. So thank you for joining us, and perhaps we'll speak again and see how it's actually working out. And
thanks so much. Really appreciated the opportunity. Thank you, Keith, for inviting me, and enjoy the rest of the day. Bye now.
Thanks.
Great. So happy bucks. Yeah. Oh, I see money waving in the air. Come on up.
Well, I never thought I would be having happy tech bucks, and I sure am not a happy tech person. I can be happy, but not a happy tech person. But after listening to this presentation, kind of hit home. Yesterday, we got a text from our grandson. He was in a pub in London, England, having a plowman's lunch. And how that came about is some months back, and we just found out this out a few weeks ago. A few months back, he had applied for an IT job, IT company out of Luxembourg, who is relocating, they're starting an operation up in Canada. So he applied, and he got the job. So Saturday, he flew out to London, England for 2 weeks. And then a week in Luxembourg for training and orientation, and then back home. And Carol and I are just so pleased and happy for Eric. Maybe he can teach me some tech. The old guy.
So happy buck both for today and for making up for all of lost, not all of lost time, but a little bit of lost time over the last year or two. So just a happy buck, a bit of an update on Bob. So he's doing well. Of course, he's lonely, but I would say he is doing well. And the happy buck is he came up to the cottage with Bev and I this past weekend, and he really enjoyed that. I think the comment was he hasn't slept in a different bed since he moved into Seasons, and so this is the first time he slept somewhere else. And his comment was it was the most comfortable bed he slept on. So I don't know if that's a memory issue as well as, but he had a really good time. Bob and I sat in many hours and we did a big puzzle, and so we almost got it done, but I finished it just in time before the weekend was over. So it was a good time for Bob, and I was glad he was able to get up and enjoy it. So.
I've got a couple of happy bucks. I took Hannah for her first interview for her apprenticeship. We haven't gotten the position yet, so we're still looking. If anybody knows any welders who are looking to take on apprentices, keep us in mind, but she was very, very nervous, but she came through it well. And his final comment was, well, next time you come, will you bring your helmet so you can actually show me some welds? So we figure that's a good thing. Anybody online have any happy bucks? No? Oh,
Michael's.
oh, Michael.
Just wanted to say thank you so much for allowing me and Connie to join in this morning and listen in to see how you guys are running your meeting. It seems like you're doing this seamlessly and it's integrating very well. It's going to be a great model for us to borrow some ideas, and congratulations for getting back to in person. Looks like you're doing a great job. Thank you.
Thanks, Michael. Sorry I missed you on the weekend, but
Oh, you sure missed a great weekend. Sorry to, we'll have to meet up sometime with over coffee.
there you go. Yeah. And sorry for the folks of you who are online and not here. I promised there were treats here today. So there were baked goods. So I'm not going to say they'll be every week, but you have to show up to find out. So we're going to move on to our committee report. Doug, you've got a membership report for us?
Good to be back up again. So membership, we've met a couple times, and so we're obviously just beginning to do a number of things. Really, our focus this year is both the traditional like new member. I'm going to call it recruitment, although it's more attraction is how I would describe it. And then once a new member joins, it's the introduction to the group, to the club. And then also what I think can be missed very easily because you focus on new members is current member experience, current member engagement, and retention. So those are the kind of the three kind of buckets that we're looking at. We're going to continue to go forward with a number of the things that we started last year, we were working on last year, and I mean as well as previous years. But I know that Steve and Gord had sort of that first contact and follow-up that they kind of started last year, and we're going to continue with that. Steve and Gord. Oh, I meant to mention membership on committee is myself, obviously, and then Steve, Gord, Mike, Dave, and Gary Peters. So that's our committee. So Steve and Gord are going to continue with their efforts on that first contact, reaching out, having those initial conversations, and that engagement with them, potential new members. We also have a list that was generated last year of everyone that's indicated interest or that had been recommended as a potential new member. So we're just going to be going through that, refreshing that, updating it, and then using that so that we know if anybody's reached out, who's following up, what's the lead, what's the status, and so that nobody slips through the cracks. Another area is looking at getting back to our in-person activities. Obviously, our meetings are just beginning to be back in person, but there's a number of things that has kind of gone by the wayside, obviously with COVID, and that is, for example, the Fireside Chats. So for a new member that comes in, the ability to meet one-on-one with someone, just have a fireside chat so that we can begin to bring them into the club, answer their questions, and kind of describe to them what the club's about and how everything works. One of the other things we're looking at is there's been lots of conversation about ideas over the last couple of years, going back to we had a survey and we've had a number of other different types of things where we've collected ideas. We want to go back to all those ideas and just kind of look through, were there any good ideas that may be relevant today that might be a good idea to move forward on and go from there. And again, a key part of that one, I think, is mostly on the current member experience and engagement. There's been lots of good ideas. We haven't necessarily acted on them all. And so we're just going to go back and comb through those and look for any good ideas. So having said that, for new ideas, if anybody has any ideas for us to consider, please reach out and let me know. And we'll see what we can do. Any questions?
One of the things I feel quite strongly about was the new members committee. To get retention is not an easy thing. If people join and they don't become involved right away, they ain't going to stay. Cornwallis started something many years ago, which was with new members, a separate committee. They were given money, some fiscal responsibility, and allowed to make their own decisions. I believe that this year, probably because of COVID, it's not there. And I feel strongly that needs to be maintained. I think it's a prime example of what needs to be done, and I keep recommending it to other clubs in the district. So I'd like to see it back in place again.
So there, I'll speak to that, Doug.
I was about to say, well, we just spoke about it at the board meeting, but I'll turn it over to.
Yeah, so they are getting back together, you know, again, it was a COVID thing, you know, so, but we have reached out to those of our members who are eligible for the new members committee. So they're working on doing something for our respite kids for Christmas. We're going to ask them to do, because Johanna was so great last year organizing walks and hikes and things like that, something that easy that they can do. So we're going to work on that, and we're just trying to sort out the financials for them so that they can do their Christmas party. So it's a little scaled back from other years, but everything's scaled back from other years. So yeah, but yeah, we're working on them. Yeah. So we're working on a co-chair situation, which I think moving forward will be good. We're going to have like a senior new member and a junior new member, if that makes sense. And then the junior new member will then be the senior. So we'll always have a co-chair so that, you know, they can work off of each other.
If you see it as a breeding area, the last 5 club presidents have all been in the new members committee.
I think we've all been chairs.
They've all been chairs of the new members committee. So
Not this guy,
you were there as well, Steve.
but I wasn't a chair.
Not a
Just saying.
chair.
You should have been.
Yeah.
But yeah, so
Yep.
that's the type of thing that comes out of it. So
Yep.
anyway.
Very good.
Okay,
Good.
thanks.
All right, thanks, Doug. Okay, you have an announcement?
Just a reminder that the Christmas trees come Friday afternoon, late afternoon, probably 4:30, 4:45, 5 o'clock. And they usually arrive when it's getting dark, and we're done by the time it is dark. So if you can give us a hand unload, that would be great. This is, I believe, our 27th year. And Bob Stevens started it, I believe, in 95.
Yeah, and Ted's also going to change the sign when he goes on the way home, because if you drive past Watson's right now, it says Christmas trees start on the 22nd. They don't, they start on Saturday, the 20th. So if you're scheduled for the 20th and 21st, those are still your shifts. And again, I know Ted sent out the schedule. I'll just remind everybody, if you can't fill your spot, please find a replacement, or at least let somebody know so that we can try and find a replacement. Joe? Yeah.
Yeah, very briefly. So it's a little less than 4 weeks till the concert happens. And I just wanted to remind people that we really do need sponsors. If you know of anybody, either your own company or another corporate sponsor or another individual who would like to sponsor us, I ran out of paper, so I only have 5 of them here, but I sent it out online, and it's also on our concert Facebook page. The link to the outline for sponsors. They're basically 3 levels. 250, 500, and 1,000. You get little things for each. And I just have some hard copies here. I know that one person at least said, hey, can you give a hard copy? Because it's easier for me to work from a hard copy than it is to go online to do that. So sponsorships are going to be really, really important. Yeah, ticket sales are going to be great, but we have no idea how they're going to go. And so the real money is going to be made from people who can find sponsorship. So anyway, I've got them right here. If anybody would like a piece, I have them here.
All right. I also wanted to let everybody know that our Christmas party, ours, not for the kids, but ours, is December the 23rd, which is the Thursday right before Christmas. We're going to be having it at Boston Pizza at their outdoor patio. It's been booked for 6:30. I do need to have a better idea closer to of numbers. So if you're planning to come, if you're bringing a spouse, you know, we just need to have that idea so that we can let them know. If anybody's concerned about the fact that it's an outdoor patio, I have it on good authority that you won't even need a jacket. It's so warm on there. So, you know, everybody try and come. I know it's right before Christmas. I know people are busy that time of year. Come for an hour, you know, Merry Christmas. Let's just get together for a little bit and have a little bit of fun together.
Are we doing gifts for that? or
So
just-
more will come.
Okay.
Yeah, I'm working on a plan. So, but I just wanted to put the date out there so that you guys can get it in your calendars. And then, as I said, let me know who's going to be coming and with spouses so I can let Boston Pizza know. Any other announcements? Anybody online have an announcement? No, I can't really see.
Amy, I just
Yes?
want to say, anyone that can't do their Christmas tree shift, my son Isaiah is still getting his community hours, so he would love to help out more than what we're on the schedule for. So if anybody has an issue, I can get Isaiah over there ASAP. Okay.
Perfect.
Tell him to come on Friday evening. Ted Watson's to help us unload trees.
This Friday. Okay. Yep.
Tell them to send me a text or an email about that. I'll see what I can do. I don't think I have his name on the list.
Yeah. Isaiah Hall, Leanna Hall. We're on the list twice, but thanks, Ted. I'll do that. Yeah.
Hey, Ted, I've got two for you as well. So I'll send you names and you can slot them in as much as you want.
I love how we volunteer our children and their friends. All right, Rebecca, I believe if Rebecca's still there, oh, there she is. You have our quote.
Yes, I'm here. Can you hear me okay? Perfect. So my quote's kind of short this week, but I think it was very meaningful. So my quote is, "Service to others is the rent you pay for your room here on earth." And Muhammad Ali said that.
Very good. Yeah. All right. It's a little early, but for this girl who's got a very long day ahead of her, she's okay with that. So if there's nothing else for the good of Rotary, thank you, Michael and Connie, for joining us. And we look forward to getting your hybrids up and running. And thanks, everybody. Have a
I
great,
just got
oh,
one.
yeah, sorry.
Thank you, Jason, for your sponsorship of the concert.
Yay, Jason.
No problem. Love it. It's a
Thank you.
great cause.
Appreciate it.
Cheers.
All right. Okay, everybody have a great week.